Hello, everybody. This is Steve Edelman, one of the co-hosts of our TCOYD podcast. My other star co-host, Jeremy Pettis, is now on his way to Germany. And we are really privileged to have a good friend and colleague, Leslie Eiland, who is an endocrinologist, also living with type 1 from Omaha, Nebraska, who flew out to our San Diego studio to do this particular podcast on pregnancy and type 1 diabetes. So my first question to Leslie will be, can you help define what gestational diabetes is and talk about what we're going to focus on during this podcast?
Sure. So when it comes to pregnancy, there are, probably different categories when it comes to diabetes in pregnancy. There is gestational diabetes, which is diabetes that is diagnosed during pregnancy, and we usually find that out when somebody does their oral glucose tolerance test in their second trimester. There are also women who have had type 2 diabetes already diagnosed prior to pregnancy, and they may or may not be on non-insulin medications or insulin for their type 2 diabetes. And then what we're really going to focus on today is people with type 1 diabetes in pregnancy.
Right. And would it be fair to say that if you get diabetes during pregnancy, it's mostly of the type 2 diabetes type?
It's probably gestational, although I do have a couple patients who were diagnosed with type 1 diabetes during pregnancy, and that was a little tricky. It often wasn't clear what was going on, and they sort of realized it after delivery when the blood sugars stayed high.
Okay, perfect. So let's say you're a female with type 1 diabetes and you want to get pregnant. What are some of the things that they should be thinking about?
Yeah, so I think it's really helpful to just know what to expect, to do your homework, to understand what happens with insulin resistance during pregnancy, and to let your medical team know with some advanced warning would be nice. I think it's important to talk to your endocrinologist that you're considering starting to try to conceive. And some endocrinologists will manage their patients during pregnancy. Sometimes they send them to one of their partners that specializes in diabetes in pregnancy. Sometimes they send them to a high-risk OB doctor that also manages diabetes. It really, really differs from health system to health system. And so I think it's just important to know if and when you get pregnant, who will be managing you during that pregnancy.
So I know that working with women with type 1 who plan pregnancies, they work with a high-risk OB and they get super tight control actually before conception, because talk about the perinatal morbidity and mortality as well as complications at birth as it relates to glucose control.
Yeah, so I think it's, so along those lines, I think it's really important to have a pre-conception OB visit to review all these goals, and like you said, get your blood sugars in as tight of control as possible, even prior to conceiving. We don't want someone to start with an A1C above 10 and get pregnant and then sort of have to rapidly decrease the glucose level significantly.
How long before conception you want to have a good A1C?
You want to have a good A1C prior to conception. Yeah. So I think a few months ahead of time, if not, 3 to 6 months ahead of time would probably be reasonable.
But I would say in my experience, Leslie, most times the pregnancies aren't planned. And I guess the best you can do is once you find out, obviously see someone that can manage you during your gestation and try to get it under good control as possible.
Absolutely. Yeah. Do you want to go over the risks?
Sure. Let's do the risks.
Uncontrolled blood sugars in pregnancy. So when the mother has high glucose levels, the glucose levels cross the placenta, and the baby develops high glucose levels as well. The insulin does not cross the placenta, but the baby has a functioning pancreas, right? And so when it's swimming in this high sugar bath, the baby's pancreas starts making a lot of insulin to make up for that. Mm-hmm. And so insulin is a growth hormone, right? It's an anabolic hormone. And so that can lead to the baby getting too big, too fast, and way too much. And it can be a disproportionate weight. Like their shoulders can get bigger than the rest of their body. And that can cause a problem during labor and delivery. There's an increased risk of shoulder dystocia. And then when you have a baby who's just been, whose pancreas has just been making a ton of insulin after delivery, that pancreas continues to make a ton of insulin even though they're no longer in this high sugar bath, and that can lead to serious low blood sugars right after delivery. We call it neonatal hypoglycemia, which needs to be monitored closely and sometimes treated pretty aggressively.
Yeah, and is it true that although these babies are large for their quote-unquote gestational age, they're internally immature and premature, I should say?
That's my understanding. Yes.
And then they have to be in the ICU longer than other babies as well.
Correct.
So you've been talking about tight control. Give us an idea what the A1C should be, and also if they're wearing a CGM, I hope, what kind of metrics should we be looking at?
Yeah, so we'd like an A1C, less than 6 if possible, with minimal hypoglycemia, which is really hard to do without a continuous glucose monitor, in my opinion. Like we said, it's best if that A1C goal is achieved prior to pregnancy. If we're looking at kind of finger stick data, we would like fasting glucose levels less than 95. We want 1 hour post-meal blood sugars less than 140 and 2 hour post-meal blood sugars less than 120. If you're using a continuous glucose monitor, that time and range goal is still above 70%, but the goal or the range shifts and becomes much more narrow. So for people that aren't pregnant with type 1 diabetes, their range is 70 to 180. For people in pregnancy, that range shifts to 63 to 140. So it's much tighter.
Yes. Now, what happens during, let's say, the stages of gestation? There's the first trimester, the second, the third. Unfortunately, it's kind of a moving target, right? Because the needs change over time.
Absolutely. So first trimester, even until the end of the first trimester, you may be more insulin sensitive, and sometimes your insulin needs won't increase much. They may even go down a little bit, especially for women who have trouble with nausea and vomiting during the first trimester of pregnancy. You're at increased risk for hypoglycemia with that. But beyond sort of 16 weeks for most people, that's really when your insulin resistance rises exponentially. And by the end of second, third trimester, you may be needing 2 to 3 times the amount of insulin per day compared to your pre-pregnancy needs. Usually by like mid-end of third trimester, things level off. But like you said, you're a moving target, and my team usually reviews blood sugar numbers on every 1 to 2 weeks, but often on a weekly basis to try to stay on top of it.
In general, would you say the duration and severity of hyperglycemia dictates the health of the baby?
In general, yes, but you're correct. I think I've seen so many exceptions to that. People with, numbers and A1Cs above goal throughout pregnancy that have no complications, and people who just work their butt off, all 40 weeks and do have complications. And so I think there's a lot that we don't understand about this. There's a lot, I think, just variation from person to person, and we can't predict.
Yeah. Now we know that having good control means you have a lot of % of your time in range.
Right.
So how bad is having hypoglycemia, and on the other end of the spectrum, hyperglycemia, including diabetic ketoacidosis?
So DKA in pregnancy is extremely dangerous. It actually has a pretty high mortality rate. So that's something we want to avoid at all costs. If you have, a 200-300 value on your CGM that you rapidly correct and comes back down, and it doesn't happen very often, I think that alone, it happens. I think it's really hard to maintain tight control for 40 weeks. And so when it comes to highs, we're really concerned about the just prolonged highs that go on for a long time. With lows, the risk is primarily to the mother. And I think if you have a lot of hypoglycemia, you start to not feel your lows anymore. And so that can be dangerous from a safety standpoint. So we always encourage people to make sure their glucagon is up to date and their loved ones know where that glucagon is, and go over CGM alarms and sharing their data, things like that, just to try to keep them as safe as possible, because it's hard to run this tight for so long and not have hypoglycemia.
When CGMs were first coming out, they were super restrictive, the insurance companies. But if a woman was pregnant, they let them have it. What a godsend that is. Now, what if you had a woman with type 1, she gets pregnant, and she wants a pump. What's your approach to someone that has never been on a pump before and they're already pregnant?
So my understanding is that the data is very similar in terms of outcomes, whether someone is on shots or a pump. But if somebody is at all thinking about switching to a pump during pregnancy, switching to a pump before they get pregnant is recommended. I think it's, sometimes it's hard. The transition from shots to a pump can be a little rocky at times if we don't have a lot of great information. And so we advise to not do that while pregnant and to try to do that earlier.
Yeah, you're right, because people who are not familiar with pumps, they have a higher risk of going into ketoacidosis, and that's not a good thing. Right. Let's talk about diet and exercise. I mean, people with diabetes, women with diabetes, I should say, ice cream and pickles, lay around, don't overdo it. I gained 10 pounds when my wife was pregnant with our first child.
Interesting.
I did.
So I think, I don't recommend the pickles and ice cream on the couch for 40 weeks. I think as long as you are somebody who is normally active and has a normal exercise regimen, for the most part, you should be able to continue doing that. Certainly talk to your OB and your OB team. And there may, if you're doing extreme weightlifting or things that can affect intra-abdominal pressure, that could be an issue. But for the most part, if you're doing a moderate exercise routine, you should be able to continue that during pregnancy. And it's encouraged. We're trying to keep these post-meal blood sugars just so flat. And so walking after meals is huge to help combat those post-meal rises.
Yeah, that's awesome. Now, what else do people have to worry about or should know about?
Well, I think some people, in order to maintain a relatively flat line on their CGM or not have a lot of fluctuations, want to eat like super low carb, and that can be really tricky. So there aren't great guidelines around this in pregnancy, but certainly going to a dietitian and getting some counseling could be helpful, because we really want you to avoid calorie restriction. You need to get plenty of calories to help the baby grow. We want you to still eat carbohydrates. I think it's better if those are spread out throughout the day. And if you can choose like lower glycemic foods or more like complex carbs to prevent those blood sugar spikes, but you still need to eat carbs. And so pre-bolusing, like putting in that bolus 15, 20 minutes or more sometimes prior to meals can help. And like I said, the walk after meals can help curb that spike.
They all sound like techniques every person with type 1 should use to strike the spike.
And sometimes this is like pregnancy is the ultimate motivator, and we hope that you learn these techniques during pregnancy and then continue to use them post-pregnancy.
I'd imagine there's going to be a schedule of things that a woman with type 1 who's pregnant should do. How often she'd be seen, maybe some proactive communication with their employer, ultrasounds. I mean, you don't have to go through the list in detail because no one needs to memorize those now. But I think that's important to know that there's a lot of things that people should do to not have any surprises at childbirth.
Yeah, I think it's really important to work with a multidisciplinary team that does this a lot, right? Because I think type 1 in pregnancy is very different than type 2 or gestational diabetes in pregnancy, and you need a team of people that understands that. You're going to have a lot of visits, so like you said, it's important to work with your employer early and make them aware of that. You're going to be sending your blood sugar data to your endocrine team every 1 to 2 weeks, and you get quite a few ultrasounds. You usually get one early on, you get a more in-depth anatomy scan halfway through, and towards the end of your third trimester, you're getting very frequent ultrasounds and also very frequent non-stress tests, sometimes once or twice a week. The delivery date that your team sets really depends on a lot. Depends on how things are going in your pregnancy, what your glucose levels are looking like, any prior history with prior pregnancies. And so that's something.
They estimate how big the fetus is, correct?
Yeah, I don't think they're super accurate at that, but yes, they do estimate based on ultrasound measurements. And so sometimes that may depend on, if they want to induce you closer to 37 weeks or if they'll let you go closer to 39 weeks. It really just depends.
This is a serious question. Is there a phone app for women that can put in the numbers and they say, yeah, you're going to deliver on September 6th, and then the baby could be born on the same day as me?
I have no idea.
They have apps for everything.
They do. Okay, I'll look into it.
Okay, now it's time for labor and delivery. Most guys don't know what it feels like to have a baby. And I've heard that you can equate it to the pain of a kidney stone. Is that true?
I have heard that. Actually, once I had a patient who had a kidney stone while pregnant. So she experienced a kidney stone followed by labor in like pretty quick succession, but she told me the kidney stone was worse.
Well, I've heard that's the best way to describe the pain to a guy.
Yeah. Makes sense.
How about you? How'd you do with your two boys?
Actually quite well. I had like a great team of high risk OBs, and I had a continuous glucose monitor, and it was harder probably like mentally, emotionally, just to try to be so vigilant for so long. But ultimately, I have two healthy boys, and I feel very lucky.
That's awesome. So what else should people consider for labor and delivery? What's important to take away from our talk today?
So, it kind of depends on the hospital system. Some people will let you stay on your insulin pump during labor. That's not what we do in our system. It's not my preference. We tend to want people to run in a very narrow range during labor and delivery so that, we decrease the risk of the baby having hypoglycemia after they're born. So we like to put people on IV insulin. And if you're on IV insulin, unfortunately, you're getting hourly pokes. But that is how best to keep you in a really, really tight range. You can still wear your CGM throughout labor and delivery. Just kind of think of where you're putting it to make sure it's not going to interfere with any of like the monitoring bands that they're using during labor.
The question is, when are we going to use CGM in the hospital environment? And that's because a lot of people think it's crazy to prick your finger when you got a CGM on. It gives you a number every 5 minutes.
I know. I think we've made a lot of advances in that over the last few years, but I think we're still often having to validate that CGM data with, the hospital glucometer. Change is hard.
Well, yeah, change is slow, especially with big bureaucratic organizations. Well, after delivery, what's different for a woman with type 1 compared to a woman without type 1?
Yeah, so people with gestational diabetes, if they need to be on insulin during pregnancy, really can just stop the insulin immediately after delivery. Type 2 is different, just depending on sort of what sort of treatment you were on prior to pregnancy. But with type 1 diabetes, you don't want to stop the insulin. You can go into DKA that way. But as soon as the placenta is delivered, that's what makes the hormones that cause your crazy insulin resistance during pregnancy. So as soon as that is delivered, your insulin resistance tanks and you become very insulin sensitive. And often for the first few days or weeks, you may need less insulin than you needed prior to pregnancy.
This insulin resistance that you're talking about that goes up during pregnancy, I'd imagine that when someone is under really good control, when they conceive, the insulin resistance is minimized compared to someone who has very poor control?
That's a good question. Everyone is so different. I don't know that I've been able to predict that.
Yeah, there's a lot of unknowns, as you said earlier. Well, what other changes happen postpartum? I know that there's a big difference with women who breastfeed versus formula feed. How does that affect anything?
Yeah, I think
and other aspects.
Yeah, if you're breastfeeding, especially early on, that can lower your insulin resistance even more. And so we worry about hypoglycemia during nursing. This is just a time of so many variables. Your diet is inconsistent. Your sleep is extremely disrupted. You may or may not be breastfeeding. You have new stressors in your life. And so it's really common to feel very overwhelmed. I think moms without diabetes feel very overwhelmed at this time, and you throw in still having to manage your diabetes that has changed so rapidly. It's a lot. You also, used to be sending your blood sugars in weekly to this medical team, and not that you don't have them anymore, but people aren't asking for your data as frequently.
They're done with you.
You lose this team. Like they have dumped you after a successful delivery. And so it kind of feels for some people like the bottom falls out and they're just left to deal with all of this stuff. And it can be really overwhelming. I think it's normal to feel depressed and anxious during this time. It's normal to have more diabetes-specific distress, and it's normal to feel like you need more support from your family or your healthcare team to manage your diabetes.
Yeah, it sounds like women with type 1 who deliver may have more issues with distress. And like you said, regular diabetes distress. Now, this postpartum depression that we all hear about, does it happen more in women with diabetes?
I haven't seen a statistic around that, but I certainly know, having diabetes postpartum can just negatively affect the transition to motherhood. So I would not be surprised if the statistics were higher.
Well, I'm going to go home tonight and thank God that I'm a man, and because this sounds really hard. In our last little part of the podcast today, what can you suggest to help people?
Yeah, I mean, I think it's important just to realize that your type 1 pregnancy is going to be different than your friends' pregnancies that don't have diabetes. And some people really, don't like how medicalized the experience is. And then there's just this big focus on data that you feel just solely responsible for, and its effect on your child that can be really damaging in some ways. It's common to feel just deprived of a normal pregnancy experience, but there's some things that can help. I think if you trust in your healthcare team and feel confident in their abilities to manage, many other women with type 1 diabetes and that they've had good outcomes, I think trusting that team is really important. Sharing your experience with other people with type 1 diabetes is important. There are Instagram groups and Facebook groups that can support women in pregnancy with type 1. Just having active social support with your loved ones and feeling like you're just a part of the decision-making process, I think can all be helpful.
Wow. That was a lot of really good information. And I would say my very last question to you is, what advice would you give the male spouse of a woman with type 1 who's pregnant? What if the person who's pregnant is not even there? You had all these guys in a room. What would you say to them to help out? And obviously the obvious ones are, be supportive, and you're going to say that, but say anything you like.
So I think that's a good question. I don't think anyone's asked me that before. I think
that's why I'm a podcast co-host.
So I think just like the normal day-to-day stuff would be helping with meals, right? I think if you're trying to eat low carb but not too low carb and sort of trying to balance all that, sort of working together to prepare meals, going on walks together after meals, I think would be helpful. During labor and delivery, one thing that I prepared my husband for was I knew I wanted to be on IV insulin during labor, but after delivery, I wanted to get off that IV insulin as soon as possible, just to not be attached to an IV and a pole and not have hourly finger sticks. And so just in case I was not equipped to get my pump out and change my pump settings and fill a cartridge, I made him do a couple pump site changes for me and fill the cartridge with the insulin, and just so I would know that he'd be capable of doing that, just to help me get back on my pump during that time.
What about, probably one of the most difficult thing would be to understand first and then deal with the swings in emotions from your loved one who's pregnant. And I think you have to have some level of understanding and empathy that, your partner may have mood swings.
Oh, absolutely.
Is that fair to say?
Absolutely. Yes. Another thing I found very helpful was that he would always make sure I had carbs when I was like sitting in a recliner nursing my infants. And because you can go low frequently, and sometimes I would sit down and just realize that I did not have anything next to me. And so he would always bring me usually a giant tub of Costco animal crackers.
I was going to ask you what's your go-to.
It was a tub of Costco animal crackers.
Containers.
Yeah. That's
I love
great.
Those.
Yeah.
All right. Well, I think that we've covered a lot of ground. And I think, for me, I learned a lot, even though I deal with women who are pregnant, but they get shot off to the high-risk OB. A lot of women don't have that. Right. I just think it's important to have a level of awareness that your loved one who's pregnant that you knocked up is going to need lots of support. And it's going to go through mood changes, and because they have type 1, there's supply issues, there's hypo issues, and I think just being the best partner you can and always being available is my advice.
Absolutely.
Thank you, Leslie.
Thanks for having me.
Okay.